It's okay.
Yeah.
So we are very, very glad to all the people who have joined our meeting. The issue we want to discuss with you is advanced prostate cancer in patients with cardiovascular disease. 2 weeks ago, there was another webinar, and there you have discussed the paper by Dr. Margil and collaborators from Israel. And we thought that it will be great if we again can gather together and to discuss it with the author, to give him some special questions, and to discuss the ongoing collaboration need between cardiologists, oncologists, and urologists. So I have a few slides to make up some scale of the problem. As you all know, with this recent publication in New England Journal of Medicine, mortality due to prostate cancer goes down in US. You see these excellent graphs, but still now it's very important problem, and we know that more than 180,000 people, new cases of prostate cancer were detected in 2019 in US, and it was associated with more than 30,000 deaths. The connection that we have between cardiovascular disease and cancer are multiple. It goes through inflammation, through thrombosis, hypoxia, epigenetics, and shared risk factors. This wonderful cartoon is taken from Mosley Group's recent publication, and it shows beautifully hypothalamic pituitary gonadal axis and the targets for androgen deprivation therapy in prostate cancer. As we can see here, we have GnRH agonists, GnRH antagonists, orchiectomy, a surgical option, CYP17 inhibitors with abiraterone here, and androgen receptor antagonists with a lot of new drugs here that all are doing the same, blocking or taking down testosterone. This has profound metabolic activation, and this causes some kind of cardiovascular problems. And if we see in the literature, and this brief review from Mosley Group shows that as a pooled group, androgen deprivation therapy has positive associations with cardiovascular events, but it goes among 3 meta-analysis observational studies, but none of the 3 meta-analysis or randomized controlled trials shows this association. So we have the discrepancy between real-life data and randomized controlled trials. GnRH agonists have strong positive associations with CVD events among the meta-analysis observational trials, and antagonists with the Garolex on board has no association with cardiovascular death and stroke among 3 meta-analysis observational studies. So we have the kind of problem here. We do not know exactly by randomized controlled trials if there is any association, any meaningful and clinical association with cardiovascular adverse events, but there is some very strong signals by observational studies. This relationship was undiscovered by AHA, American Urology Association, and American Cancer Society late in 2010, when American Heart Association released a statement together with these societies that acknowledging the possible association between ADT and adverse cardiovascular events, and more recently, prostate cancer survivorship care guidelines by American Society of Clinical Oncology endorsed evaluation and screening of cardiovascular risk factors in men receiving ADT. And it looks like that cardiovascular and metabolic effects in men receiving ADT must be evaluated according to USPSTF guidelines for screening and evaluation of cardiovascular risk factors, blood pressure monitoring, lipid profiles, and serum glucose. The same goes for NCCN guidelines too, for prostate cancer survivorship. So there are some pathophysiological backgrounds standing with this. GnRH agonists and antagonists in terms of cardiovascular risk, there is some differences. GnRH antagonists suppress both LH and FSH, as opposed to GnRH agonists, which suppresses primarily LH. And maybe it may influence how these molecules affect endothelial function, lipid metabolism, and fat accumulation. So when we have such kind of signal that giving in 6 randomized controlled trials men with pre-existing CVD GnRH agonist cardiac events were 2 times more than in men treated with GnRH antagonists. And the authors of this wonderful paper from European Journal of Urology in 2014, they call prospective studies to provide more definitive data on the type of ADT to use to avoid for men at high cardiovascular risk. And graphs look like this. In blue, we see the GnRH antagonist, the Goralex, compared with other ADT drugs. And you see this difference here. And now, recently, a few weeks ago, they published a very interesting study from Taiwan. They took retrospective cohort of 44,000 men with prostate cancer. Only ADT was about 2,700 people, and others wait and see strategy. During median follow-up of 2.65 years, they had 1,650 deaths, and ADT was associated with increased risk reduction in all-cause and prostate-specific mortality in men without stroke, CAD, and CHF in the age group of 65-79 year group. It means that if you have the patients who are older than 80 without or with major CVD, or younger than 80 with major CVD, you have no survival benefit with ADT. So it's observational, retrospective study, but it's very strong message that patient with CVD can be treated successfully with ADT. How it goes? What's the pathophysiological mechanism? It behaves with abiraterone acetate, one of the representatives of the study drugs, cause low potassium, LFT abnormalities, blood glucose goes up, and blood pressure the mechanism most likely of primary aldosteronism. And there is a need to reach out specialists like endocrinologists or cardiologists. There are a lot of drug-drug interactions with these new drugs, and you see here that a lot of drugs like statins, like DOACs, calcium channel blockers, even some kind of ARBs, they have an interaction with these new drugs, and many medications will be rendered almost ineffective by co-administering with enzalutamide and apalutamide, and very challenging to take these patients back in the balanced situation. And what we have to do before starting antiandrogens, we need to get condition under control. How we can do it? You see that most common adverse event for novel antiandrogens is hypertension. You see it's for abiraterone, for apalutamide, less than darolutamide, and enzalutamide is again, hypertension is quite frequent. Then a lot of metabolic changes in cardiovascular adverse events, and you can see that אני לא יכול לדבר, אני באמצע מרצאה פה. And management of metabolic changes in cardiovascular adverse events, we have to screen the patient at baseline and throughout treatment. Mineralocorticoid excess cause hypertension and hypokalemia, when we have to correct this before beginning the treatment. And cardiovascular adverse events, about this we can educate the patients with regular exercise, dietary modifications, and for controlling and preventing hypertension, DVT, and PE. 4 years ago, Javid Mosley published this clinical update paper in Circulation about cardiovascular effects, and he supposed these ABCD steps to reduce cardiovascular disease in patients with prostate cancer. It's general preventive things we do all these patients about awareness, aspirin use, blood pressure less than goal, cholesterol, high-intensity statin therapy, smoking cessation, and controlling diabetes, diet with exercise. But there is no randomized controlled trial that show that this strategy works as well as with other people. And at this place comes a wonderful study that was done by our colleague David Margol that hopefully will connect soon and will show his data. And it's brilliant presentation that shows that in generate agonist groups in patients with cardiovascular disease on background, they have 33% of total cardiovascular events versus only 5% in generate antagonist groups. And you see here the time to first in any cardiovascular event, and it shows up that there is some kind of precision medicine, even in terms of cardiovascular risk reduction in prostate cancer patients. So my conclusions are that hypertension and metabolic abnormalities are frequent during ADT therapy. We have to recognize the need to balance oncology efficacy against potential risks of therapy for patients with baseline cardiovascular diseases, to inform patients about the adverse events and try to make always shared decision. It may be wise to send candidates for ADT for cardiology consult for the risk assessment and co-management. Urologists, uro-oncologists, cardio-oncologists, nurses, and clinical pharmacologists must work together for the optimal care of advanced prostate cancer patients. Thank you for your attention, and we will get your questions. Daniel?
Yeah, so we're still working on it. Hopefully he'll get in here. I would want to go back to your one of your first slides, the recent paper in the New England Journal. Could you maybe go through a little more detail on that one?
Sure, just a moment. Actually, the paper is talking about the need of PSA screening, and the paper goes against that and shows clearly here there is a bump in the mortality during when the widespread PSA screening was initiated. And it shows actually that maybe prostate cancer related mortality is stick mortality. It's not real rise, but stick, because these people in their 70s and 80s probably have another problems too. And you know, when we have cancer, everything is related to cancer, and it's not always true. And actually this paper shows this kind of thing.
Well, I think that this is something, you know, I've given presentations before where I showed the, you know, cancer survivorship, and over the last couple of decades, the survivorship, 5-year survivorship, for example, has improved dramatically. And you know, that's for all cancers, and some cancers are more impressive than others. But one of the common features every time I've looked at that sort of data from like the American Cancer Society website, that it has prostate cancer as greater than 99% 5-year survival. And, you know, I think that I've always wondered about that, because if you thought about any cardiovascular problem, regardless of what it is, hypertension, high cholesterol, whatever, to have a 99.5% 5-year survival for any cardiovascular diagnosis is unheard of. You just can't imagine that. So why would prostate cancer be protective for life? Making a diagnosis of prostate cancer, you know, confer an almost guaranteed 5-year survival rate. I just don't get that one. And I think that it's because that data is cancer mortality. So when you have a diagnosis of prostate cancer 5 years from now, you're not going to die from prostate cancer. You're going to die from cardiovascular disease. And so, you know, I don't know if you get a sense about all that from this paper you just highlighted. And
yes, actually we are talking about that. This kind of paper shows that we have to look at the larger picture, and larger picture shows that these people do not have only one problem; they have a myriad of problems, and probably the things that we are doing now, we have to improve the management of the whole battle problems than only one single problem. Because of this, we're not able, like cardiologists, to treat their prostate cancer, but we can be of aid to maintain the cardiovascular health. And at the same time, our oncology and urology colleagues will treat their prostate cancer. They have to choose between different options they are getting every day, from immunotherapy through androgen deprivation therapy. And probably together we will be able to improve these patients' prognosis. That in terms of survival, they have from the cancer, but their cardiovascular death probably goes up with this ADT.
Yeah, and I guess the other thing is, and you know, you can hopefully we can get David on here, but the you know, from the paper that we reviewed, you know, two plus weeks ago, there were a couple of very interesting findings from there, and I think you showed a little bit of data from it. Just that, you know, the number of cardiac events was much higher than expected, especially if you think it was a relatively small study. It was only 40 patients in each arm, and you had significant cardiac events in a relatively short period of time. And
exactly.
So that, again, that speaks to this sort of disconnect between, you know, the apparent really great 5-year survival of prostate cancer and then the actual reality.
Because of this, we have some kind of discrepancy I showed on this slide here. We have the meta-analysis shows that the discrepancy between the association with androgen deprivation therapy with cardiovascular events with observational studies, but none in 3 meta-analysis of randomized control trials. It means that in randomized control trials, we have highly biased population, probably with low risk in terms of cardiovascular disease. And this is not the case in the real life, when everybody gets the very effective oncology therapy, but the oncology therapy probably will have detrimental effects in terms of cardiovascular diseases. And this is the point that was highlighted brilliantly by David's group, that showed that it's very high risk of cardiovascular events, and that was shown in this slide here. You see that? Yeah, here. You can appreciate that for 1 year follow-up, 2 death, 1 MI, 2 CVA, PCI with stents, cardiac-related ER visits. Total, it's some 33% of cardiovascular events. Altogether, it's 15 events among the group of 80 people. So it's very high incidence for 1 year. And probably it shows the real life that these guys are coming with uncontrolled hypertension, maybe not so good control of diabetes and lipid profile, and everything goes up when you use these metabolic very active ingredients of ADT therapy. And probably there is a need to do some more studies to look carefully in real life, and again, probably randomized controlled trials with the focus on cardiovascular issues in these patients.
Yeah, so we had talked before, and I know Dan and I were going to meet at ACC meeting, which of course didn't happen. And we were trying to discuss how could we, do some combination study between, for example, the US and Israel, and exactly in what format would that study be, or how would you do that to look at the cardiovascular events in patients with prostate cancer? So I don't know if you've thought about that anymore and what you might think.
Yes, I think at least some people from Israeli Oncology Society, genitourinary oncology group, are on the line, and we have a couple of meetings with them, and they're very eager to collaborate with this kind of study. And I think the main thing should be the very precise surveillance, cardiovascular surveillance of these people, even to do an observational study when the oncologist is choosing the therapy by oncology strategy, and cardio-oncologist is trying to balance the risk factors of the patients and to make their cardiovascular status as good as we can. And this may be important in things of even further improving the prognosis of these patients. I think such kind of study should be done, and it's possible to do even in Israel. And if we can join forces together with ICOS, and under ICOS it may be even multinational study.
Yeah, so one of the other concepts that we talked about, and you had mentioned that there was some interest in Israel in regards to this, is, you know, CT, either, you know, CT angio in terms of diagnosing coronary disease. But one of the other things, and we talked about this to our own group here in WashU, about for the most part, all patients with prostate cancer, before they are initiated on some therapy, get a CT of their abdomen. And on that CT of abdomen, they're looking for, you know, cancer ramifications.
Yes.
But if you look at those CTs, especially the non-contrast image, you see extensive vascular disease in most cases. And when we presented it to our own urology group, they were like, "Oh, we never even seen those," because, you know, that's just not what they're looking for. And yes, so I wonder if we could do some study looking at, you know, baseline CT studies, and you know, documenting the extent of vascular disease based on the baseline CT, and then integrating in some fashion a CT angio, if appropriate, for the evaluation of coronary disease. But I think at a minimum, we already, as part of the general evaluation, you already have a CT abdomen that has, you can document the evidence of calcific peripheral vascular disease.
Yes, I think the idea is to identify with all means the atherosclerotic disease in these patients. When you see calcified aorta, when you see calcified femoral arteries, all of these guys are getting CT. And probably the idea is to identify these kind of things on the first meeting with the patient. And when we see these calcifications, send them to cardiologists to make them to take their LDL down and to make their diabetes more treated by disease-modifying agents. Now we are fortunate to have these kind of drugs like Jardiance and Forxiga and GLP-1 agonists too, that have modified the atherosclerotic disease in these patients. And it happens quite early. So we have the time to intervene and to improve the cardiovascular prognosis of these patients. From the beginning, when they are diagnosed by prostate cancer, their cardiovascular disease is not the side problem. It's the main problem along with cancer. And it must be recognized by oncology colleagues. And the collaboration, I think, is the key here, because we are all wanting the same thing. We want a patient to live longer and happier. And we can do this together. I'm afraid that happier we won't be. I don't know if we can make them even more happier, but healthier, probably yes.
Well, I think that.
David, you can give your comments. Dr. Sarid, can you give your comments, please?
Yeah, I think it's very important issue today we discuss here. From our point of view, from oncologist point of view, we need to balance very well oncology efficacy again, potential risk of therapy for our patients with baseline cardiovascular event. And so we have more and more solid data in the literature about toxicities of our treatment. And toxicity is because of depletion of testosterone mostly. And we have more and more potent hormonal treatments which cause more depletion of testosterone, and so risk is go up, and generally oncologists try to administer most efficacious treatment for our patients for prolonging life, but still very important to send high-risk group patients to cardio-oncologists for close follow-up and for best cardiological treatment. So I think still we need more data and more trials, and I will be glad to organize with my colleagues a broad randomized trial. We have all facilities in our centers today in Israel to organize a very good, high quality trial, and I think it must be our next step.
So one of the things that Zaza and I were talking about a minute ago, I don't know if you heard any of it, but was, well, sort of two main points. Number one, the long-term outcomes from prostate cancer appear to be extraordinarily good, in the sense that when you look at 5 or 10 year survival data, that the numbers are super high, and they're higher than we would expect for just your average male who has heart disease that's previously undiagnosed, et cetera. So I think that the way that I have interpreted that data is that it is cancer mortality. So they're not looking at all-cause mortality, they're looking at cancer mortality. So do you have a sense about that, or is that a correct observation or not? No.
David or Dan, can you comment on that? Dan Gillon.
I'm sorry, I didn't hear the essence of your the two last sentences.
Danny is back. Hi, Danny.
Yeah.
Okay. Yeah. No. Basic point is that the oncology outcome data for prostate cancer is super good. It looks really good. 99.5% 5-year survival or 10-year survival, which is far better than any other cancer. But we all know in reality that those patients aren't dying of prostate cancer, they're dying of cardiac disease. And if you had all-cause mortality, a 5-year survival rate for prostate cancer is not 99.5%. This is my contention. I was just trying to get some sense about that.
It sounds very logic. Can you hear me now?
Yep.
And I think, I'm not sure what you've discussed earlier, but it goes with the general impression, I think, in cardio-oncology in general, where you have good results in oncology and better survival. We know that there's in the last 50 years, there are 5 times more diagnosis of cancer, but there are 9 times more success in resolving it, either partially or totally. So it goes with the basic issue that you survive cancer, but you pay with other complications, mainly cardiovascular. So I think it is in with the context, but only recently it has been shown specifically in prostate cancer in the results that you've just mentioned.
I guess the other question is what Zaza and I were talking about earlier is if you have a situation where a baseline CT scan of the abdomen that is typically done for people with prostate cancer, and you document the evidence of peripheral vascular disease just by that CT, you know, could that stratify patients to higher risk versus lower risk? And I don't think anybody has reported on those findings.
Yeah, I think we've mentioned it that you have suggested with Zaza and myself to try and look into it. I think there's a high chance that it is a true issue, and we all know that it's today we're talking about when talking about PAD, not only about peripheral distal arteries, but also about coronaries and the neck arteries. So we know you could, once you have one of them, you have a high chance of adding the others. So if we already have the CT of the abdomen anyhow because of the cancer, this specific prostatic cancer, it seems very logical to try and look into it. So we'll have a sign and probably with high sensitivity, and it will be a good issue to look into.
And I think the other question is that is it possible to extend that CT to include a calcium score, for example? So if you could do a calcium score in the chest at the time that you're doing that baseline score, I mean the baseline CT, then you might be able to really maximize your CT imaging in these patients at baseline. It's going to be done routinely. I don't know what you think about that.
I think it's feasible, and I've discussed it to my better understanding CT persons in our institution and also others. We've discussed it also with Zaza. I think it's feasible and can be of a high level of importance. Maybe you will not get the exact numbers, but you'll get the mild, moderate, or severe, and this way find a way to use it.
And do we have Dr. Sarid back on, or did he get kicked off, or?
He's on.
Yeah, I think, I think very interesting question could be combinations of hormonal treatments. Today, oncologists use more and more combinations, not only ADT. We use ADT combined with second-line hormonal treatment in metastatic patients. So next trial, which we could organize, must include this group of patients who receive combination treatment. So and look for cardiovascular toxicity in this special group of patients. More and more, our patients in metastatic setup and locally advanced prostate cancer setup receive combination treatment today. So it will be a good idea to look for cardiovascular toxicity and in this group of patients and publish it with data.
So it's Joe. Zaza, nice job, by the way. Yashar Kara.
Thank you. Hi, Joe. How are you doing?
So I just wanted to expand what Dan just said about abdominal CT scans. So in our overall mentality, we always talk about chest CTs, but you can get. Dan pointed out that.
Ale to możesz po prostu odłożyć na bok, wiesz, kochanie.
That you can get excellent information about risk and vascular disease by looking at abdominal CTs. Also, there are arteries and there's an aorta that shows up, so that if there's calcification, you know, I'm a little bit binary. It's either there or it isn't, and I'm not that concerned about a score to make a decision about being aggressive in treatment. But it's there, and that I just want to remind everybody that don't just look at chest CTs. There are CTs in other areas where you can get comparable information.
Yeah, I agree, Joe, in general, but I also think that I was just trying to think of how you could extend routine imaging to get, you know, a calcium score, for example. That shouldn't be difficult because they're already in the CT scanner and it doesn't require contrast. So all it matters is, you know, just moving the scanner up a little bit. And if you could add that to a baseline CT abdomen, then what you would do there is you could stratify people, even though, as you said, you're binary, whether it's there or it's not, I think is certainly a reasonable approach. We do know that if your calcium score is above a certain threshold, then you're at very high risk, as opposed to if it's 0 or below 100.
Yeah, so in Israel, it may be easier to do than in the United States. I think that I've had like lots of discussions with the radiologists, and they won't put a calcium score in because it's not reimbursable, and they think the whole imaging would be not paid for if they added it. So that's the rationale in the United States for not doing it, Dan.
Yeah, but you know, the thing is if you do a CT calcium score by itself, I mean, most of the time you can get it done for about $80. So I mean, this doesn't make sense. I don't see how you can.
It doesn't make sense.
But by the way, even if you take into consideration the limitation that Joe just mentioned, you could probably, as a side gain, might have the size of the abdominal aorta, which we know is important to know, and include some degree of risk relevant to the patient at this age. What do you think about it?
Yeah, I mean, I think that's, you know, we've talked, you know, at previous points in my life, you know, when I was thinking more like an internist, you know, you would, you know, consider whether you should get a screening abdominal ultrasound to measure the aorta. And then, you know, how, as a screening strategy, how useful was that? So, I mean, as CT and measuring the aorta and actually doing a calcium score, those are much better tests than, you know, whatever preventive strategy you may have thought about years ago with an ultrasound. So, yeah, I mean, it seems to me that that makes a lot of sense, and it shouldn't add an expense or a time of any significance to a CT scan. It just means using all the information that you have on the scan in more detail.
Okay.
So I guess my question is that in the workflow for our urology or oncology colleagues, you know, how difficult would it be to be able to, you know, add these components to the baseline CT?
It goes to the Dr. Sarid, right? The question
Yeah,
goes
if
to
I think he's still on.
Yeah, what is the question, please?
How difficult or how challenging would it be to put into the workflow for evaluation of a patient with prostate cancer these two other, you know, considerations: a measurement of the aorta, a documentation of the amount of calcium in the abdominal aorta and iliac vessels, and or a CT, a calcium score of the chest?
So I think it's possible, but it could be done in trial, more in trial, before it will spread to community. I think it's very important to do in clinical trial first. So in this case, we could be aware of useful information and spread it in community thereafter. So it's my opinion.
Yeah, have you felt like you've noticed that on most of the patients that you're doing the CT abdomen, and whether, you know, whatever treatment you were discussing with them, did you ever notice that there was a lot of calcification, or did that not really show up on your radar?
Yeah, it's important to pay attention to these calcifications on CT or PET CT, and include this information into judgment, clinical judgment. Of course, I completely agree with you in this aspect.
And then, you know, in the study that we were talking about earlier, they did the endopat, and that, you know, can look for endothelial dysfunction.
Yes.
You know, it makes me think that we didn't really see any difference between the groups with endopat, but I wonder if, for example, I don't think there would be a change in endothelial function if you had existing peripheral vascular disease. So if, say, for example, you had significant aortic calcification and you were doing some trial looking at endopat, but in those patients that had a very calcified aorta, I don't think endopat's not going to change. So I wonder if part of the reason why you didn't see anything with the endopat was because a significant portion of those patients had significant abdominal vascular disease.
So Dan and Zaza,
Yes.
it might be interesting to go back, if you have a registry of prostate cancer patients, to look at deaths in the last 5 years, and then go back and look at their abdominal CTs and see if there's calcium there, and get a sense of how predictive that is of non-prostate cancer death.
Yes, it will be
Sounds possible and very relevant, I think.
Yeah, and I mean, I think if you don't find anything there, then, you know, then we can shut up and we just won't bring it up again. But if if it somehow it like seems really obvious that there is a difference and it's related to the amount of calcium noted in the vessels, then that would be an extremely important finding, and it's one that's, you know, it's kind of it's a blind spot. You know, people don't really see that. I mean, when you do any kind of CT, especially for cancer purposes, they're very detailed about looking at all the masses and other things, and, you know, with exquisite detail measuring each one. But frequently they don't even comment on whether all the vasculature is calcified or not. So those are radiologists that, you know, that's just it's a blind spot. They don't really recognize that as important parts of the CT. So
Couldn't
anyway,
agree more, I think.
Well, I sincerely apologize for our challenges this morning. This was a new one. I will say that our time is up, but I do think that we are so happy that you guys were able to present, and we love your study and your data and your interest. And if we can refine it in some way in the future, that would be really great. Also, I do think, as Dan and I were going to meet at ACC, we should probably meet at least electronically and try to sort through how we can, you know, do some multinational study. So I would definitely want to do that.
We'll be happy to do that, and hope to get over the corona soon. Maybe we'll meet at the next ACC, but we'll talk about it earlier, I hope.
Yeah, I don't want to wait that long because I don't know when that's going to happen.
It will be
Okay.
at the end of the summer at ESC in Amsterdam. You're all invited.
I don't think the ESC is going to happen.
No,
Right.
You guys may think differently, but I don't think so.
So, Daniel, you'll have to come then. You and the other friends come to Tel Aviv earlier.
We would have. We were planning on it,
Okay.
but
I know.
you know, those Israelis, they shut down their airport and everything else, you know, because they didn't want any bad juju there.
we're opening slowly up. It's okay. So thank you all. Thank you very much.
All right. Thank you guys so much. And we really appreciate all your effort. And also you have expanded our vista to now we have to think about how we can change our webinar structure to have more than 100 attendees. So
Right.
thank you for that great challenge.
Thank you very much.
Thank you very much. Thank you.
Thank you.
All right. Thanks a lot, everybody. All right.
Thank you.
Take care.